ETCM channel of emergency medicine. I'm Dr. Preeti. Today I'm going to present a case who had come to our ER. He was a 40-year-old male. Came with complaints of cough since 3 weeks, fever since 3 weeks, and breathlessness since 2 weeks. Patient was apparently normal 4 weeks back, but he had developed sudden onset fever with cough. Fever was on and off, which was low grade with no evening rise of temperature. Cough was dry cough with no diurnal variation and no post-stressive discharge or nasal discharge, for which he had taken antibiotics in a local clinic, and he was treated for that, but it was not subsided. Later, he developed breathlessness, which was gradual in onset. Initially, it was when he was climbing stairs with exertional activity. Then it further progressed to feeling breathless when he was sleeping also. Then it has further progressed to rest since 2 days. That's the reason he had come to our emergency medicine department. And there was no associated chest discomfort, palpitations, no associated syncope, hemoptysis, no associated rash, joint pain, or loose to abdominal pain.
Why you are asking abdominal pain, loose stool, syncope? Is there any reason or just asked?
Syncope, because we have to rule out any cardiac, if there is a reduced cardiac output, there can be HOCM.
Especially
So
young
individuals.
Young male HOCM, aortic stenosis or something like that, we have to rule out.
Diarrhea, because it was associated with fever and there can be associated GI symptoms. So we had asked for that. Past history, no significant co-morbs, but there was a history of accident in 2012 where he had a L5 S1 spondylolisthesis. Post that he had an internal fixation, and no relevant family history. Personal history was normal. Sleep was disturbed because of the breathlessness of the past 2 days. Appetite, bowel and bladder was normal. No addictions. From the history
what
part,
type of addictions can produce cardiac disease?
cocaine and all can cause
Cocaine, amphetamine can produce tachycardia, coronary artery disease. Then
and
alcohol.
Smoking and alcohol are like risk factors for the cardiac failure, atherosclerosis.
Okay, then IV drug abuse.
IV drug abuse
Can produce
sudden onset
First of all, that is a different thing. That is adrenaline or something. IV drug abuse. Which side?
Mostly
Tricuspid.
because right side.
Okay. Tricuspid valve infective endocarditis can be possible if the patient is repeatedly taking drug abuse, like drugs. Okay.
So from the relevant history, the summary is a 40-year-old male with no known comorbs, on and off fever since 3 weeks, which was not resolving with cough and worsening breathlessness, initially which was NIHA grade 2 and progressed to 4, presented with above mentioned complaints where we had taken DDs as probable infectious cause initially, like it can be a probable LRTA and can be a probable acute bronchitis. Since fever was there since 3 weeks in our Indian setting, we can think of TB also.
3 weeks fever, breathlessness, pleural effusion. The first common diagnosis what we can make in our country. But like you told, your examination finding may reveal something else. But TB is the most probable diagnosis one can make.
Now when we go into the examination, patient was conscious oriented. There was no pallid icterus cyanosis clubbing lymphadenopathy, but bilateral pitching type of pedal edema was there. And pulse rate of 118 per minute. It was a normal volume pulse, normal character, regular rhythm. BP of 110/70. Respiratory rate was high. He was tachypneic, 42. And saturation was 90% only on room air. Temperature was normal. And on inspection, we could find that there was elevated JVP, almost 10 centimeters of water, and on inspection there was hyperdynamic precordium, and apical impulse was seen. that is in the left fifth intercostal space, not in not an enlarged down and up, no, but
It's not
hyperdynamic,
shifted down
not
and
shifted
up,
up, not
but it
shifted
is
down
in
and
the
up,
intercostal
but
space.
it's in the
It
fifth
is
intercostal,
hyperdynamic.
hyperdynamic pulse you could see. And visible epigastric and suprasternal pulsations were seen when we had looked at
So when you are telling
the
that,
engorged veins.
okay, so it's only inspection finding.
Mm.
When you are palpating that, you have to see whether it is occurring with the apical impulse or after or before apical impulse. That is very important.
Left parasternal heave was also present on palpation, and there was systolic thrill.
Okay, same
Over
thing.
the mitral
Parasternal
area.
heave can be systolic or diastolic. Is it systolic parasternal heave, diastolic parasternal heave? Both are important because right atrial,
Enlarged.
right ventricular enlargement and left atrial enlargement both can produce parasternal heave. So that also you have to tell. Ideally, whether it is coexisting or it is co-occurring along with the first tarsal or apical impulse, that is very important.
On auscultation, there was a pansystolic, high-pitched, blowing type of murmur at the apex in mitral area. S1 was soft, and S2 I couldn't appreciate it as a wide but a murmur, pansystolic murmur was heard at apex, grade 4 with thrill and high-pitched blowing type of murmur which was radiating to the axilla.
What are the radiations of pansystolic murmur in the mitral area?
It can be to the parasternal area when there is posterior cusp involvement. Axilla can be anterior cusp involvement.
It will radiate apex or base.
Apex or
Apex means axilla,
Axilla.
base means
Base
towards
means
the
towards
aortic
the-
area. What are the reasons for a long systolic murmur in the mitral area? So it's a long systolic. You have made a diagnosis of possible MR in this case. But as a medicine postgraduate, you have to tell me what are the reasons for a long systolic or pansystolic murmur in the mitral area.
Pansystolic murmur can be in aortic regurgitation, mitral regurgitation, and there can be in VSD also.
Aortic regurgitation produces daily diastolic murmur in the subaortic area and pansystolic murmur in the mitral area. But that is occurring in it can occur. That should not be the first reason.
Pathology.
It can be the last reason. What is the first reason? When you see a pansystolic murmur in the mitral area, what is the first?
MR is the first thing. MR is the most.
Anybody who is having a pansystolic murmur in the mitral area, first diagnosis is MR. What is the closest differential diagnosis for that? MR is the clinical diagnosis. What else can come as same murmur? Don't tell the reasons for MR. TR.
Yeah.
How do you
Yes.
differentiate TR and MR?
Wait.
What is decarbolus?
Decarbolus. Actually, all the right-sided murmurs will be increased on inspiration. So
All
that
right-sided events will increase on
increase on
inspiration.
inspiration. So in TR also.
So TR increases, whereas MR
MR
decreases.
decreases.
On expiration, MR increases, TR decreases. There is a closest differential diagnosis because both areas are the same areas, very short distances. They can have a misdiagnosis of MR or TR. Okay, so that is the thing. Now, what are the reasons for MR there in an individual diagnosis?
It can be etiology can be in valvular pathology we can think of. That is, it can be leaflet pathology if it's involved, then it can be infective endocarditis or RHT we can think of. There can be mitral valve prolapse.
So, three diagnoses: MR due to MVP, MR due to infective endocarditis, MR due to RH. In these three diagnoses, which is the most common thing? Which is the most possible diagnosis in this patient?
In this patient, infection
So
was there.
you have a
so
patient who is
clinically-
having high degree fever for last 2-3 weeks, and you are seeing a murmur in the mitral area. Most possible diagnosis for a postgraduate make is infective endocarditis. But what is the reason for infective endocarditis at this age? Is it rheumatic heart disease or MVP with MR? There is a
There should be a previous history of
rheumatic heart
rheumatic
disease.
fever
Normally
like
rheumatic
not
heart
treated.
So rheumatic heart disease and MR, it occurs at what age group?
Young,
It is younger age group.
individuals.
It progresses very fast, and younger age group itself, patient will come to the hospital. Whereas MVP with MR, they have a long period to come to the hospital. They never notice that. Okay, most of the time MVP can be innocent for many years. Suddenly they have some problem and it can aggravate. So MVP with MR is one differential diagnosis, and on top of that, he might have developed infective endocarditis. Okay. RHD is a possibility, but he has not given he hasn't given any past history of any such illness. Okay, so that is very important. You have told about AR. Is it possible here?
Yeah,
You have to talk like a postgraduate. I am asking a very straightforward question. Will you make a clinical diagnosis of AR here or not? You have told AR that can produce a pan-systolic murmur or long systolic murmur in the mitral area. That is also correct. But can you think that as a postgraduate is a AR or not?
Other features like BP, like
It is
that
very
all
important.
things.
So you have to see the other features of, see, when there is a AR with MR, there is a severe lesion. Left ventricle has to be enlarged. So you get a shifted out and out down apical impulse. The BP will be very high. Systolic BP will be very high, and there will be wide pulse pressure. Nothing is there. So we may not clinically make a diagnosis of AR here. And you are having another important feature to localize the lesion. What is that? Localize the lesion in the mitral area. What is that? You have another important finding. What is it? You already told.
Axillary radiation.
Yes, told. And you should be thrilled about your diagnosis. That is it. Thrill.
palpable thrill was
Alphabet thrill localizes the lesion. That is the importance of a thrill. So you get a murmur due to various reasons in the same area. It can be due to anemia, it can be due to thyroid, it can be due to pregnancy. Like you told that it can be AR and producing a murmur in the mitral area. MR itself can producing a murmur in the mitral area. But if you have a thrill, you have nothing else. Only mitral regurgitation. It's a valvular lesion. That is the importance of a thrill. Thrill localizes the lesion there itself. Okay. So you have already told AR. That's why I'm asking AR again. What is Gallabadin's phenomenon?
the musical sound which will be
Everything is musical sound. All murmurs are musical sound. So you cannot tell a musical sound. What is Gallabadin's phenomenon? Emergency medicine is not required. So since you told AR, I am asking. Otherwise, we should never ask. Gallabadin's phenomenon is seen in which type of lesions? It's a condition seen in elderly individual. It produces two types of murmur, but actually there is no lesion. One is, it is actually aortic sclerosis. Aortic sclerosis produces two types of murmur. What are the two types of murmur? One, it produces an ejection systolic murmur in the aortic area. Because of that sclerosis of the valve, that produces a vibration, and that vibration sound will go back to the mitral area. So that produces another sound there. That produces a long systolic murmur in the mitral area, and ejection systolic murmur in the aortic area. But actually, there is no lesion. This is the commonest problem in exams. You get a patient who is having absolutely no problem. But on auscultation, you get two sounds. One ejection systolic murmur in the aortic area, one pan-systolic murmur in the mitral area. Patient is absolutely normal, pulse is normal, BP is normal, everything is normal. Then your diagnosis, aortic sclerosis with Gallabadin's phenomenon. So that you should remember. But this is a young patient who is having fever, you have a MR finding, you have a thrill, so everything localizes this. There. Is it mild, moderate, or severe MR? How do you grade the lesion according to clinical findings? What are severity findings of MR? One is grading of
Grading of
murmurs. Systolic murmurs can be graded. Diastolic murmurs can be graded or not.
No,
It is
we
not.
can't grade.
So it cannot be graded according to the current classification what you are learning. So here it is a severe murmur. So that is one point. Second point is S3.
S3
Is there
because
an
of the
S3?
increased.
If there is an S3 that produces that indicates more severe lesion. Then cardiac enlargement.
And cardiac enlargement.
So that also indicates severity of the lesion. Then clinical finding, is it producing orthopnea or not? So that is again another feature of severity. Okay. So this patient is having moderate to severe MR. Okay. Severe MR, you are not able to find clinical findings, but symptom-wise, it's a severe MR. Okay. How do you proceed now? This patient come to emergency room. What do you do? He is having breathlessness. He is having a cardiac lesion. What do you do?
First, we need to stabilize his breathing. That is, the saturation was on the lower side.
So
Hence, we have to
oxygen.
start on oxygen. Since his JVP was elevated, and when we get an X-ray, we can see if there is any pulmonary edema features. That is, there can be like the fluid overload. Then we can start on BiPAP, NIV, and we should give Lasix. Furosemide, we have diuretics has
What is
to
the
be given.
BP of this patient?
110/60 BP was on
Lasix can be given. Doctor question should be given. Then you can start NIV for this patient. Okay.
and we have to reduce the afterload of the patient. So vasodilators can be given.
Which one?
Severity can come. We can give nitrates,
Okay, can give nitrates.
nitroglyceride,
Okay.
and,
Right. Nothing wrong, right?
ACE
Okay.
and ARBs can be used.
CARP can be tried, but it may not
In the
be
acute
like it may not be effective at all.
Particular,
Okay, may not be effective. Only thing which is going to work is furosemide.
Nitro.
Furosemide. That will work and it will relieve the symptoms of the patient. Other things may not work because it's a valvular lesion. That's why it is not a ventricular failure because of the IHD or something. It is a valvular lesion. You have to treat it. Now, how do you rule out infective endocarditis?
By an echo, we should rule out initially, and cultures.
Okay, so you ask for a culture, you can ask for transesophageal echo. Thoracic also okay, but transesophageal is the ideal thing. Okay. Now, what are the conditions?
Later, we had done the routine investigation, CBC, CRP, and in that it showed high counts with elevated CRP, and X-ray showed a pulmonary edema picture, diffuse homogeneous opacity was there, and the right lower lobe consolidation was also present with that. And ECG was sinus tachycardia with no LVH or left atrial enlargement. Findings were not there. And cultures we had sent, and we had went cultures we had sent, and we went ahead with an echocardiography that showed good EF of 60%, but there was a severe MR and mildly dilated LV with mild dilated LA, and there was moderate to severe PAH also. Was also present, and when the echo was done, the papillary muscle head was swinging. There was like rupture of the cardiac tendon. Hence, the cardiologist had suspected that to be a.
What is the difference between rupture of papillary muscle, posterior mitral valve, and anterior mitral valve? Is there any difference?
Yes, posterior mitral valve is actually clinically.
How do you differentiate?
They'll come.
Anterior mitral leaflet dysfunction. Murmur will radiate to which side?
Murmur will radiate to the
Axis.
axis.
Opposite.
Opposite.
Anterior will go to
Will go to
posterior.
posterior.
Posterior mitral valve will go to the base. There is only difference in auscultation. Okay.
If there is posterior involvement, we have to rule out inferior wall MI also because that is supplied by RCA alone. And so echo was done, that was showing the findings. Hence, he was taken up by a CVTS consultation, and he was taken up for the emergency mitral valve repair surgery. He was taken
Repair
up.
or replacement?
Repair was.
Repair was.
Okay.
Okay.
With a valve leaflet on the top. So
Okay.
post that, he became better now.
Okay, is there any infective endocarditis?
There was no vegetation, sir,
Vegetation.
when they went with the surgery.
So in a patient with this okay, in a patient with mitral valve prolapse, you are doing a lot of procedures in emergency room. Somebody who have MVP, will you try to give infective endocarditis prophylaxis or not? MVP.
We have to give infective endocarditis.
Is your opinion?
Post surgery then?
Surgery is okay. He's got a
Research
this
and
one
any
that definitely you have to
procedures
give.
we have to give.
So how many MVPs will come?
Yes, sir.
You are giving for all? What is the current
Actually,
guideline?
most of them are not diagnosed.
No, it's okay. Once you diagnose it, what is the indicator? What is the guideline whether to give or not? MVP alone, there is no need of infective endocarditis prophylaxis. But MVP with MR, you need to give infective endocarditis prophylaxis. What is MVP?
Mitral valve prolapse. It's a myxomatous mitral valve due to accumulation of the glucosaminoglycans. The leaflet will get thickened. The anterior and posterior leaflet. Initially, there will be a mitral smile, but later when the MVP progresses,
So
the
what
entire
happens in
smile
mitral
is
valve
lost.
prolapse?
There
Goes
will be
up or down?
prolapse
Prolapse
Up.
it will go to the
up
Atrium.
because of the legal station.
Okay.
It goes into the atrium, and there will be, if there is any heavy strenuous exercise or anything, there can be rupture of the papillary muscle. The caudate tendon get ruptured.
it's your theory. Normally that valve, normally fixed, your valve is fixed there,
Fixed.
but when there is mitral valve prolapse,
Um,
it goes up.
there
It goes, it closes. Then normally it closes and it goes up. That's all. Nothing else will happen. But after a long time, it is not because of the strenuous exercise. BP patients are, they can do any type of exercise. It is not an issue at all. But over period of time, because it is going up and down, like you told, valve, that tendinate, caudate tendinate can rupture. Once it ruptures, it produces MR. Once MR occurs, then all the other complication occurs. And even if there is a small MR, patient can develop this one, infective endocarditis on that valve. That is the only issue. Otherwise, MVP is actually an innocent lesion. But once you do an echo and you are going to tell the patient all this history, all these complications, finding, then what will happen? Then what will happen? This is a common problem we create. This is called as, I think there is a name in medicine, neurocirculatory asthenia. What is that? Neurocirculatory asthenia. What is that? Asthenia means what? Weakness is very tall, thin individual. Weakness. Neurocirculatory asthenia. What is it? Somebody is having MVP. You do an echo. You tell you have a mitral valve prolapse. Your valve is going to prolapse. Somebody is MR. So next day onwards, you develop anxiety, fear, palpitation, everything. This is called as neurocirculatory asthenia. So if it is MVP, nothing to worry. It is all normal. Only thing they can have some palpitation. You can use beta blockers to prevent that. That is more than sufficient. But if the patient develops MR, then we have to be very careful. Infective endocarditis prophylaxis has to be given for such patient, and we have to follow up the patient. Otherwise, it's all right. What happens to the patient pain?
Right now, he's feeling better with the
Antibiotics?
surgery. He was treated based on the diagnosis. There was an atypical pneumonia panel which was already sent
Okay.
because initially LRTA was also suspected. In that, Legionella and influenza came out as positive.
Oh.
So those were also treated with a gram-positive coverage was being given for the patient because surgical procedure was done.
Okay. So that may be the reason for triggering the heart failure. You might have already had MVP which was unnoticed, and now because of the infection it has increased. That is the reason. Okay. Anything else you want to tell?
I want to tell that even in such acute conditions, physical examination is very essential for the patient. Only like not even one diagnosis what I felt, because my mindset was when I saw him it was only LRTA because of the history which I was getting. The importance of physical examination is important, and early management with Lasix and all was also had made him better.
Okay.
Because at that time of the diagnosis, we were confused with the ABG also because it was showing type 1 respiratory failure
Okay.
initially in the ABG. So we were thinking, is he going into ARDS?
Okay.
Kind of.
Like that.
So all the differentials as a PG, I faced the difficulty at that time. So when I read about the whole MR and all, I realized that the intervention